This is the lung portion of this video series. Again, I'm holding up more than one probe to signify that lung ultrasound has been described with all three of these transducers and more. The original classical work, and some of the current work still, because the grandfather of ultrasound is still quite productive, was performed with a microconvex probe. So something like this, just very small. The phased array transducer is very popular and works fairly well. It doesn't image the near field that great, but as long as we're not after the pleura in great detail, it'll work fine. If you want to image the pleura itself and not much deeper, the linear transducer is your best option. So it only makes sense that a happy medium would be the curved abdominal transducer. It can give you a pretty good look at the near field or the superficial structures like the pleura, and it can also give you a decent look in terms of depth. The beauty when compared to a phased array or a microconvex is you can sometimes capture multiple rib segments when you're scanning in a sagittal orientation. So we'll try 2 or so different transducers and go through the lung exam. It's important to note that there are many versions of the classic lung examination, and they range from a simple 4 regional evaluation per side to a research protocol that looks at 28 different points. That last one would drive most clinicians mad, so it's rarely employed. And most people do something like a 4-region or a 6-region per side protocol. The things we're looking for with lung ultrasound, well, first, a collapsed lung, a pneumothorax, but probably the next most common is the possibility of pulmonary edema or interstitial fluid. Things like pneumonia are seen very well, more so than with chest x-ray, and are tremendously gaining in popularity. What's interesting about lung ultrasound is it doesn't give you a diagnosis X or Y. It gives you signs that then you interpret as a whole and decide whether it's diagnosis X or Y. In most variations of the classic approach, the provider will be scanning in 4 general regions, getting the superior anterior lung, the mid and anterior lung, lateral, and then even more lateral to posterior. Sometimes we will have patients that are sitting up and we can get the back of their thorax even better. But we want to cover as much of the lung territory as possible without spending forever doing it. A lot of times I will start near the collarbone, and with the curved abdominal probe I can look at several rib interspaces. I'm not only looking to make sure there's movement of the pleura, but I'm also looking for things like this that we briefly saw, the B-line. You can just see it come down. It's interesting how much easier it is noted when it simply flashes by. When you freeze the image and try to go find it, it may not be as obvious. But yet, when B-lines are seen, we have to go through the cine loop, a series of images, and count the number of B-lines. And this can be tedious and sometimes a little bit inaccurate. One thing I can do, and here's a beautiful example of a B-line. It fits all the criteria emanating from the pleural line, going down far field as far as we can see with our transducer. And technically we may want to have a greater depth, but that is a beautiful example of a B-line. In this case, it's a little wider, and maybe there are 2 together, but that would still be normal because 1 or 2 B-lines per rib interspace is normal. Once you get to 3 or more, it's no longer considered normal. And the B-line should be seen from the pleural line all the way down. One thing that's important to note is if I shift over just a little bit, that B-line disappears. And when I shift back, it reappears. So it's reasonable to cover some territory here. There are those that turn the probe transverse and get in between the rib interspaces, but the classic teachings are sagittal across the rib interspaces. I can then move down to my other regions scanning across, again noting some B lines, and covering a good territory. I just don't want to miss a portion of the lung. Next, I'll look down towards the diaphragm, and then start to progress more lateral and, in fact, posterior. An occasional B line is noted, some A lines repeating, but no pathology is seen in this case. Then I can start moving more laterally, again looking for B lines, other abnormalities. And one thing that I like to do when I move more laterally is look just above the diaphragm, because in many cases when pneumonia is present, you'll see an effusion, and you may actually see the pneumonia in the lower part of the lung. This can be a very useful area to evaluate. Then I move up, and as we see here, no significant pathology. An occasional B line is seen, and I can move up higher into the axilla, covering a good portion of the lung. If I'm able to, I may have the patient sit up and actually scan the posterior aspect of the lung, especially inferiorly. There's not really any limit to how detailed I need to be, or want to be rather, in terms of covering his lung, aside from the time constraints that are typically faced. Most classic protocols described that show lung ultrasound is very accurate for detection of pneumonia and other processes either focuses on 4 or 6 regions and is not so comprehensive as to cover every square inch of lung.